All right, today we're going to tackle a topic that, let's be honest, comes with a lot of fear, a lot of guilt, and just a ton of misinformation: the cesarean section. Our whole goal here is to strip away all those myths and reframe the C-section for what it actually is in today's world. Not some kind of failure, but a powerful story of surgical empowerment and safety. So, let's get right into it.
I love starting with this quote because it just cuts right through all the noise. This whole idea of failure is something so many people feel, but it's a social pressure, not a medical reality. Medically speaking, a C-section is a high-precision rescue mission for when the standard route just isn't the safest one anymore. It's all about one thing: a healthy outcome. And really, isn't that the only goal that truly matters?
And you gotta see this, because it really shows just how far we've come. The C-section your great-grandmother might have had, totally different world from the one today. We've moved on from that old-school, high-risk vertical cut to what we call the modern LSCS. It's a low, horizontal incision that heals better, bleeds less, and, this is huge, it often preserves the option for a vaginal birth down the road. We're talking about one of the safest major surgeries performed anywhere in the world. That's a big deal.
Okay, so let's officially just, reset our thinking here. I love this analogy. Think of the birth canal as a busy one-way tunnel. Now, if there is a roadblock or some kind of hazard up ahead, you don't just keep gunning it forward, right? You take the emergency exit. And that's exactly what a C-section is. It's that well-lit, clearly marked, super safe emergency exit.
So now that we're all on the same page, it's an emergency exit. When do you actually need to use it? Let's talk about the real medical deal breakers, the situations where surgery isn't just an option, it's the safest option for both mom and baby.
First off, just a quick bit on timing, because it's important. C-sections basically come in two flavors. You've got your elective C-section, right? That's the one you schedule ahead of time because there's a known reason. And then you have the emergency C-section. That's when things change course during labor, and the team makes a call to switch to the surgical route for safety.
Okay, so deal breaker number 1, CPD. The easiest way to think about it is this. The mother's pelvis is like a doorway that has a fixed size. The baby's head is trying to get through that door. If the head is just physically wider than the door, well, it's not going to fit. And here's the key. This has nothing to do with how hard someone is trying or how strong they are. It's just physics, simple anatomy.
All right, reason number 2 is something called fetal distress. Okay, so picture this. Every time there's a contraction, it kind of squeezes the placenta. This is normal. But sometimes, the placenta acts like an oxygen tank that's just struggling to keep up. When that happens, the baby starts to run out of steam, and their safety is at risk.
So how do doctors know that oxygen tank is failing? Well, they're watching this one number, the baby's heart rate. A healthy baby's heart rate bounces back after a contraction. But if that heart rate keeps dipping below 110 beats per minute, that's the alarm bell. It's a super clear sign that the baby isn't getting enough oxygen, and it's time to get them out, quickly and safely.
And last but not least, we've got malpresentation. Have you ever tried to move a big couch through a hallway? You know it only fits one way, right? Angled just so? Well, it's the exact same idea with a baby. The whole system is designed for a head-first exit. If the baby is breech, so feet first, or transverse, meaning sideways, the risk of serious problems goes way, way up.
All right, the decision's been made. It's time for a C-section. And for a lot of people, this is where the fear really kicks in, right? The operating room. But let's pull back the curtain on this, because it's not what you see in the movies. It's actually a really calm, really controlled place.
So what's it actually like for you in there? First up, you're awake. Thanks to spinal anesthesia, you're totally part of it. You get to hear that first cry. You won't feel any pain from about the chest down, maybe just some pressure. There's a screen up so you don't see anything, and you can chat with the team the whole time. The point is, you're right there, you're part of the team, not just someone things are happening to. And the surgery itself, it's this incredibly precise 7-layered journey. The surgeon goes through each layer one by one. And here's a really important piece of info that a lot of people don't know. The surgeon usually doesn't cut your main ab muscles, they gently move them aside. That's a big reason why recovery is often faster than people think. It's a really methodical, delicate process.
Okay, surgery's over, and the best part, your baby is here. Now what? The spotlight shifts back to you, and getting your recovery off to a great start. And having a clear game plan is absolutely key.
So I want you to remember these 3 rules. Think of them as your non-negotiables. First, before surgery, you gotta fast for at least 6 hours. No food, no water. This is a huge safety step for the anesthesia.
Second, after surgery, your big goal is to get up and walk around within 6 to 12 hours. I know it sounds early, but it is so important for preventing blood clots. And third, for 6 weeks, the only thing you should be lifting is your baby. Seriously, let those internal stitches heal.
Okay, everyone, this next part is your safety checklist. I really want you to listen closely to this. A fever over 104.4, an incision that's looking redder or is leaking, pain that's getting worse after a few days instead of better, heavy bleeding, or any pain or swelling in your calf, these are all reasons to call your doctor right away. Don't wait. Knowing what to look for means you can be your own best advocate.
All right, you ready? It's time for a little myth busting. There are so many old wives' tales out there about childbirth and C-sections passed down from generation to generation. So let's bring in some science and set the record straight, once and for all.
First up, this is a big one in many cultures. The idea that eating ghee or castor oil can somehow guarantee a normal delivery. Is there any truth to it?
The short answer? Nope, not at all. Look, when you eat ghee, it goes into your stomach to be digested. That's it. It has no magical pathway to the birth canal, and it certainly can't change the size of your baby's head or your pelvic bones. It's just one of those things that sounds good in theory but has zero basis in actual human biology. Okay, let's talk about the big one. This is a huge fear for so many people. Is that spinal needle they use for the C-section going to give you back pain for the rest of your life? So here's the deal. This is a classic case of correlation, not causation. Back pain after having a baby is absolutely a real thing, but it's almost always because your posture has changed. Your core muscles are stretched out from carrying a baby for 9 months. That tiny needle stick is just not the villain here.
And for our last myth, let's talk about the future. If you have a C-section once, are you just locked in for life? Are all your future births also going to have to be C-sections?
And this is where modern medicine is just so cool. That old saying, once a C-section, always a C-section, it's old. It's outdated. Today, a vaginal birth after cesarean, or VBAC, has a really high success rate, somewhere between 60 to 80% for women who are good candidates. So there are definitely options. And that really brings us full circle, back to what this is all about. Look, it doesn't matter if a baby arrives via the main highway or the emergency exit. The destination is exactly the same. What matters, the only thing that has ever mattered, is a crying, healthy baby in the arms of a healthy, empowered mother. That, right there, is the only definition of a successful birth.